Good afternoon and good evening. My name is Carlos Cruz, and welcome to our latest webinar from CIDRAP and the Antimicrobial Stewardship Project at the University of Minnesota. Today, we are very honored to present infection prevention and antibiotic stewardship powered by Diagnostics. And we are very excited to have two speakers join us today. Dr. Lucia Leal and Dr. Luis Alfredo Ponce. Dr. Leal is from the Department of Microbiology, Faculty of Medicine from the Universidad Nacional de Colombia. And Dr. Luis Alfredo Ponce is the head of the Department of Infectious Diseases from the National Institute of Medical Sciences and Nutrition en México. Bienvenidos, buenas tardes y buenas noches. Tenemos el placer de estar aquí en nuestro último webinar presentado por CIDRAP y el Antimicrobial Stewardship Project. La presentación de hoy es infección y prevención en antibióticos a través de diagnósticos. Tenemos el placer de tener a la doctora Lucia Leal del Instituto Nacional de Ciencias, de la Universidad Nacional de Colombia. Y tenemos al doctor Luis Alfredo Ponce León del Instituto Nacional de Ciencias Médicas y Nutrición de México. Es un placer para nosotros tenerlos aquí hoy. Y ahora estaba con ustedes, que va a ser su host, la doctora Marnie Peterson. Muchas gracias, Marnie.
Thank you, Carlos, and welcome everyone to our webinar this evening. We appreciate you joining in your time with us. I have a few slides to share with you. As Carlos mentioned, I'm the host. We've got two terrific speakers this evening, and this webinar also has a Q&A session at the end. And so we definitely want to hear from you, those that have joined us, and engage with our speakers via questions through our chat box. So a few questions, a few slides that I'm just going to take you through here. So we have some disclosures. The first slide is about disclosures. We work with a group called ProCE and Clinical Care Options. And these are the group that help us prepare this content for continuing education. And we've got two continuing education opportunities, one for physicians, ACCME, and one for pharmacists, ACPE. So they helped review the content, and we've got the speakers that have provided us with any conflicts of interest that they may have, as well as the planning committee as well has provided those. So as you can see on this slide, Dr. Leal reports having in the past receiving consultation advisor or speaker fees from Becton Dickinson, and the rest have no relevant conflict of interest to report at this time. And that was been peer reviewed by a physician on staff, Dr. Christine Moore. The next slide pertains to disclosures of, just based on our conversation. So we may have a conversation in this educational activity regarding published or investigational uses of agents that may not be indicated by the FDA for that indication. We don't recommend the use of them outside label indications. However, these are opinions and to cause you to pause and think and engage with the speakers. Another disclaimer is, as participants, you have an implied responsibility to use this newly acquired information to enhance patient outcomes in your own professional development. Okay, so our CE and CME activity that I mentioned, our target audience is, of course, all of you that have joined us this evening, as well as the CE is provided to physicians and pharmacists. And we had some key learning objectives that we created for this presentation. We aim to cover how to apply diagnostics in clinical practice and how to improve utilization to decrease the burden of drug-resistant infections. Explain the importance of this connection between diagnostic and antimicrobial stewardship and how important it is for them both to be successful in your practice. And importantly, this presentation is coming from people that are speaking from Mexico as well as Colombia, so Latin America. and specifically Colombia. Dr. Leal will speak about some of the new guidelines and measures they're taking as well. So I think this is really focused in this area for important reason, and I look forward to the presentation. And the funding that has been provided to us by an educational grant from Becton Dickinson Company. And 2 more slides. All right. So this just describes the ACPE accreditation and the CME accreditation and the 2 groups that are accrediting this webinar. And it is 1.5 hours of continuing education. So we've started this webinar at the top of the hour, and we will be going 75 minutes because the Q&A session is an extra 15 to 20 minutes. So stay on with us for the Q&A. And at the end of the Q&A, this is where you go to receive your continuing education credits. And I will be posting this at the end again. So if you don't have time to write it down, and we also send it out by email after this presentation, but the website is proce.com. You have a month. July 22nd is the deadline to receive your credit. You'll take a post-test, and you'll need a code, which I will provide at the end of the webinar. So with that, I'm going to welcome Dr. Ponce de Leon to be our first speaker tonight. So he's going to come on camera. I'm going to stop sharing because he's going to operate from his own slide deck. Yeah, there he is. So we're very lucky to have him, and he's an esteemed researcher and expert. So I'm going to go off camera and on mute and let you come live, Dr. Ponce de Leon. You just need to come off mute once you're done getting your slide shared.
Okay.
Yep, and then I just need you to share your slide deck. There you are. Perfect. All right, you're all set.
Yeah. Good afternoon, everybody. I'm Alfredo Ponce de Leon. I'm from Mexico City. And today I want to, before I begin, tell you 2 things. The first one is just to be grateful to God that we are all able to be here in spite of COVID. And the second one, which is also very important, is that as you can see, I'm not an English speaker. This is not my mother language, so I will certainly make many mistakes. Please just think about them as part of the special effects of my presentation. And now, let me start by saying also that this is just me who is able to present the data that we are going to share with you, but it's the work of too many people. Throughout the last 20 years that we have been working at the Institute with antimicrobial susceptibility and with antimicrobial restriction, antibiotic restriction, and now Antimicrobial Stewardship Program, and being a part of the GRAM initiative that was published at the beginning of this year. But so it's not only me, and I hope that I'm going to make justice to all of those that forced me into sharing this data with you. So let me start by saying that.
Can I pause you just for a second? Are you able to turn your camera on just so people can see you?
Oh, I thought that I was, let me see. Oh, there it is.
I can see you now. Yes.
No, I don't know what.
Now you just have to find your
what I
slides.
did. Now, okay. So now you can see me now. Well,
I cannot, but
so.
Yeah, it's okay. We could see your slides. We'll see you in the Q&A.
Okay. I'm sorry. I don't know why you cannot see me, but it's for the best because I'm not somebody to watch. Contrary to Marnie and Elise and Dr. Leal, I'm not the one that needs to be seen. Fortunately, the slides are good. So antimicrobial selection starts by doing a thorough clinical history with differential diagnosis. And after that, you need lab results. These lab results actually tell you what the pre and post probability test and the likelihood ratio of these results will give you. And once you have these two things, then you go into individual care, and based upon these differential diagnoses and the relevant aspects of the patient, you decide which antimicrobial you're going to use. That is something that we have forgotten in the last 20 or so years, both in the United States and in Mexico and everywhere in Latin America. We are not really good clinicians, and we depend too much on lab results. And that is one of the reasons why, because we have this fear of losing therapy, that we start using antibiotics more and more importantly, we use them in the ICU. And that is the reason why we develop a lot of antimicrobial resistance, because we use antibiotics and we have a high demand for antibiotics just and simply because there is a high risk of infection. Now, antimicrobial stewardship, in fact, what it does is relates antimicrobial resistance, and we use these data, these profiles, to write up guidelines that we have to use in order to have antibiotics perfectly tailored for a patient. The reality is that that seldom happens. As you can see here, this is Germany. And some years ago, they published this study, which included all of the ICUs in Germany. And here you see the list of antimicrobials that they use. And you can clearly see how much carbapenems are being used in excess over the years. So the reason for this overuse of antibiotics, of carbapenems, is related simply because they have a crescent number of enterobacteriales that are both resistant to cephalosporins and to carbapenems. So in essence, what I'm showing here is that you use a lot of antibiotics because you already know that you have more resistant bugs. Contrary to what should be done, that is, using antibiotics when they are indicated because of the presumption that these high-risk patients may be infected by a particular bug, and that is only done if you use antibiotics in a very judicious way. So, more or less like 10 years ago, we started doing this strategic planning at the Institute in order to avoid resistance. And one of the things that we started doing is, okay, first, let's measure our ancillary practices. Let's see how well and how frequently we hand wash, and also the isolation, the respiratory and secretion isolation procedures that we follow, and how good do we follow these instructions. Then we had evidence as to what precise patterns of susceptibility to antimicrobials we had in our hospital. And to do this, we collected, as you will see later on, all of the bacteria that we detect in 1 year. And these are over 30,000 bugs that we have in this 200-bed tertiary care facility in Mexico City. And then 8 years ago, I remember the date precisely because something really, really bad happened. We started having problems with a particular strain. And so we decided that we needed to have a multidisciplinary approach with regular meetings every week. And this is especially tough because in these sessions, we have intensivists, we have surgeons, we have urologists, and we are not a general hospital, so we do not have pediatricians or gynecologists, simply because we don't have patients that have this type of pathology. So we are internal medicine and surgery only. So every week for the last almost 9 years, we have been meeting even with COVID. indeed, with COVID, we were having twice a week meetings among all these groups. And to do that, we had to think prospectively in the way in which we should focus our efforts. And to do this, we simply decided, okay, the first thing that we're going to do is individualize every patient, focus on each patient. So every Wednesday, all the residents in infectious diseases read out all the antibiotics in all the patients at the institute, which you may not believe this, but around 80% of the patients in any given day receive an antibiotic at the institute. So they read out all the antibiotics, how many days they have taken it, and the reasons why they are taking it, precisely which bacteria or anything that is related to infection that is isolated in the laboratory. And once we have that information, the group decides to give an instruction, whether to de-escalate or simply withdraw the antimicrobials. Every 6 months, we give all residents at the hospital this type of charts, which include gram-negative bacilli, the most important ones, and the susceptibility or resistance to these different types of bugs. And we also do this for gram-positives, and we do it for Candida species. And certainly, we have lots of problems. I'm not going to go into details, but just to tell you that Pseudomonas is widely multi-drug resistant. This is widespread. It's not only in Mexico City, in my hospital, it's all over Mexico. Maybe 70% of our Pseudomonas are resistant to carbapenems. That is Mexico. But fortunately, in my hospital, we do not have Acinetobacter as a problem. It has been shown in other hospitals in Mexico, but not in my hospital. And usually, Acinetobacter in Mexico is seldom susceptible to something. Simply put, is extremely resistant all over the country. So we're fortunate that we don't have this particular problem. In essence, all programs should be directed to optimal individual care. And to be able to do that, you need to have good diagnostics. You have to have a great infection control program working, and we have an infection control program, the first one in Mexico and probably Latin America, which has been working for 40 years. We have a national laboratory which can give you fast diagnostics with molecular tools and everything. And we also have this Antimicrobial Stewardship Program in place. After my talk, or at the very last of my talk, I will tell you what the law says in Mexico about this. But let me start by giving you a hint. There are less than perhaps 20 hospitals in Mexico that have these three components of the system, and an antimicrobial stewardship program in place, which is regulated by the government, less than 10. So that is the main problem in Mexico. You need to have all these three things. If you don't have the three of them, it is very difficult to be able to control resistant rates. One of the things that we started doing then was not only coupling susceptibility testing, but also antimicrobial use. And this is information for all of our main antibiotics over the last 18 years. So for the last 18 years, we have been collecting information on ecpenem, colistin, piperacillin, ceftriaxone. And the reason why I know that it's 18 years is because that's when ecpenem came into our hands in my institution. And so it was evident that we're going to be using ecpenem as a model. And in this paper that we published about 6-7 years ago, we demonstrated by the impact of ecpenem on antimicrobial resistance in a sentinel group of gram-negative bacilli. And what we found was that after we controlled for several factors, ectopenem was not associated with changes in antimicrobial susceptibility profiles, at least not in this group of gram-negative bacilli. And you can now clearly see this in the graphics. It's just that ectopenem does not have a good impact, but it does not have a bad impact. So it means that it's neutral. If you use ectopenem with a precise indication, the probability that Pseudomonas will become resistant to all the carbapenems is very slight. Then we started working with carbapenem-resistant Enterobacterales, which we were looking at because we had a history with one particular gene which codifies for a beta-lactamase, which actually has carbapenemase-resistant codification. And the history with OXA was very interesting because I had a student who right now is doing his master's in McGill, who started looking at Enterobacterales and OXAs from two aspects. One was to try to determine whether this type of Enterobacterales was produced because we were using too much cephalosporins or because we were using too much piperacillin tazobactam. So we did a case control study with one control and two cases for each control. And what we found was very interesting. It was the use of the beta-lactamase inhibitor that produced the OXA, 232 cases. It was not what we expected, but that is what we found. And then we did a very sophisticated time series analysis. This was later on from July 2013 to 2018, and we collected over 20,000 Enterobacterales. And to our surprise, only 2.2 carbapenem non-susceptible isolates were found. This is in complete difference to what you see in Colombia, for example, or in Brazil. And to my surprise, only half of them were carbapenemase producers. So 52% were non-carbapenemase producers that could be explained more by pouring problems or efflux pumps, more than what we suspected. But that is indeed what we are looking at. And this is important because one of the things that we also found was a low percentage of adherence to hand washing was also one of the factors that were creating resistance to carbapenems in our hospital, mainly because of horizontal transfer. And in this time series analysis, an increment of one daily defined dose of piperacillin tazobactam would increase 0.69 cases on non-susceptible carbapenemase-resistant Enterobacterales and 0.49 cases of carbapenem-resistant Enterobacterales. So clearly, piperacillin tazobactam is related to the incidence of carbapenem-resistant Enterobacterales as explained on its effect on OXA 232. This is a surprise? Yes. Was this what we were expecting? I would say no. We were expecting more NDMs, more BIMs, more IMs, but not tazobactam and piperacillin making the effect. So this year, we published this beautiful study, basically trying to identify if we were wasting our waters with carbapenem-resistant bugs, basically Klebsiella. And what we found is by screening the wastewater of our hospital, we were able to detect patterns of resistance among these different Klebsiella, which were expressing KPCs and OXA48-like beta-lactamases. It's not what we are looking at in patients, but this can tell you what the wastewater may be providing the community. And so we are now more concerned about what we do and try to clean up the waters and stuff like that, at least from the National Institutes of Health. So but basically, what we were actually looking at is going from individuals, and then we did a lot of surveillance, and then we started doing risk factors, but we were not looking at the impact. And if you don't look at the impact, you cannot say that this is a real threat. So in 2017, the University of Oxford asked us to contribute to the grant project. And as you know, the Global Burden of Disease Initiative, what it does is tries to measure the absolute burden of disease in population. And the better that we do it, the best that we can minimize errors in the information. And you usually just think about it as disability adjusted life years, which is a formula that you all know. And we measure health as 0 and death as 1. So this is the overall global burden of disease, which is a beautiful study. It's an initiative started over 30 years ago, longitudinal with multiple countries. And at the very beginning, it just looked at age and gender. But now, since 2018, we started collecting data on individual patients. And given the complexity of this study, we started to look initially at some points of the structure of antimicrobial resistance. We did not take into account everything. And this is an initiative that is giving us a beautiful result, and it will give us better data in the future. It starts by doing a systematic review of the literature and hospital systems. We also look at different data and the management of the data in different systems. But overall, just to look at the data, it tells you we are actually contributing all over the world. As you can see, this is not just Mexico, my hospital. There's a lot of hospitals, a lot of centers all over the world that contribute to 471 million individual data and 2,500 years of size study data. This is an incredible amount of data that we collect and we give to people that do this type of mathematical modeling consistently over the years. So this initiative took into account 12 infectious disease syndromes, as you can see here, and only 23 bacteria, 18 antimicrobials. But what was more important, we were looking at bacterial antimicrobial combinations. And before we did the actual study, we presumed that these 88 bacterial antimicrobial combinations should be the ones to look at. And this is only type of what we gave Oxford is many variables. As you can see, we put data into each and every single one of them. And there were over 159,000 admissions that had complete information with over 200 variables and 120,000 clinical isolates from this from these 19 years. This is what we gave Oxford, and this is what they modeled. Well, they say we, but to be honest, they modeled it, and we gave them the information. And then we did obviously look into the information and provided feedback. So we modeled all age and age-specific deaths and disability-adjusted life years for 204 countries. And we divided them into regions and super regions. And the basic thing that we did was we had the number of deaths where infection played a role. We had the proportion of deaths that were attributed to a given infectious syndrome. Then the proportion of infectious syndromes deaths were attributed to a given pathogen, and then the percentage of a given pathogen resistant to an antibiotic of interest was determined. And by doing that, we simply measured the excess risk of death or duration of infection based on whether it was resistant or not. And to be able to do the comparison, we simply had two counterfactors. One was death attributed to antimicrobial resistance based on an alternative scenario in which all drug-resistant infections were replaced by drug-susceptible infections, and death associated with antimicrobial resistance in which the alternative scenario was all drug-resistant infections were replaced by no infections. So this counterfactor gave us the whole picture to be able to measure the impact. And these were the results of our study. The global deaths were actually 1.27 million when they had an infection, and 4.95 million when they had no infection. So as you can see clearly, resistance has a great impact. The overall mortality for antimicrobial resistance in 2019 was 16.4 per 100,000 when they were compared with the susceptible microorganisms, and 64 when there was no infection. And as you can see in the graph, by region is exactly the same, but here's Latin America. It might not seem a lot, but just look at the proportion. So in Latin America, there are not a lot of deaths, but certainly the proportion of deaths associated to resistance is extremely high. And when you look at the type of infection, there's no surprise here. You look at lower respiratory infections, bloodstream infections, and intra-abdominal infections. But the impact of the pathogen and the susceptibility of this pathogen is extremely important. Here we have Staph aureus, Staphylococcus aureus is the one that has a huge impact. It's the one that has the most impact on death of resistant pathogens. That is, MRSA is not susceptible Staph aureus, it's MRSA. And E. coli that is resistant to cephalosporins, and E. coli that is resistant to carbapenems. And when you look at the data, you see these six account for 75% of all attributable deaths. These six pathogens, E. coli, Staph aureus, Klebsiella pneumoniae, Pneumococcus, Acinetobacter, and Pseudomonas. So if you look at the pathogen antimicrobial combinations, and this is important because this is what we should look into, you can clearly see methicillin-resistant Staph aureus, MDR tuberculosis, third-generation cephalosporins, carbapenem, fluoroquinolone-resistant E. coli, carbapenem-resistant Klebsiella once again, and Klebsiella pneumoniae that is resistant to third-generation cephalosporins. These are the main combinations in which we have to look into, and by doing this type of things, what we can do is compare it in a few years and look at the data to see if by impact, if we have reduced the impact of this particular combination. So to finish up, antimicrobial stewardship in Latin America is still, as we say in Mexico, this is just the beginning. It's just like a very long labor. There are very few programs instituted in Latin American hospitals that do antimicrobial stewardship the way it should be done. However, we do have projects, a lot of projects that look into antimicrobial susceptibility patterns in some regions and in some countries. Lastly, in Mexico, by law, since 2019, all hospitals should have an AMS program. But then we had COVID, so this has not been implemented. So in conclusion, antimicrobial resistance is one of the leading causes of death, with higher burden of disease in low-income countries. These bacteria, as I told you, represent almost 75% of all attributable deaths, And we hope that the information on the impact will allow us to focus on particular pathogen drug combinations that are more lethal, and through better infection control programs, better access to second-line antimicrobials, better diagnosis, we are going to favor the development of less deaths by resistant bugs. Many, many thanks, and I hope that I was very clear, or at least somewhat clear, and many thanks again. Thank you.
Thank you so much, Dr. Ponce de Leon. You were very clear. And I appreciate you highlighting all your efforts, particularly the Graham report, and taking our participants through that critical data. I have many questions for you at the end of this presentation pertaining to your presentations. All right, well, you're going to stop sharing. There you are. And I'll come back on video. I want to invite Dr. Leal to present the second presentation this evening, this afternoon, and we look forward to that. I'll just wait for you to start sharing your slides, and I can see them, so that's perfect. So I'll let you pick up where Dr. Ponce de Leon just left off.
Okay, thank you, Marnie. Good evening to everyone. I would like to thank again to the organizers of this event for inviting me and for your assistance to share some experience and points of view related to this important topic in the container of bacterial resistance in our region. I know that most of you work maybe in the lab or are clinicians, but I think we have, I think 20 or more % of the problems in the same way. It's not only lack of resources in Latin America, is also we need training, we need education, we need to work together and be more conscious about the problem. I think today all of us, for all of us, is clear that the fact of the global threat of increasing bacterial resistance makes it necessary to redirect the strategies available for this containment. Antibiotic stewardship is essential, of course, but solid programs integrated with diagnostic management and also infection control programs are mandatory in our countries. And we hope with the new diagnostic tools, technologies available, it will be possible to generate algorithms, pathways, to allow a personal approach, as Dr. Ponce de Leon said, to guide treatment in our specific patient. I think this is essential for us. Diagnostic stewardship is a very nice term. Nobody knows exactly what does it mean in Spanish. Stewardship is very difficult to translate. We don't have the word, like for you, as stewardship, you understand. For us, is in Spanish, optimization, something like that. But in antibiotic, it's a little bit more clear. But in diagnostic, I think is not clear for us totally. But diagnostic stewardship is defined as coordinated guidelines and interventions to improve appropriate use of microbiological diagnostic to guide therapeutic decision. This is very important. It should promote appropriate, timely diagnostic testing, including specimen collection, identification of the pathogen and antimicrobial susceptibility, and accurate, timely reporting of results to guide patient treatment. This is the cornerstone for the laboratory. The diagnostic pathway begins of course, when the patient presents at the healthcare facility, and It's covered the initial interaction with the clinician, and not only with the clinician, another frontline healthcare workers is very important in our settings, provide the first care with the patients. And the responsibility, for example, for take samples. This is more in our country, we have many problems with the taking samples. Sometimes the quality of samples is not good enough to do isolation and antimicrobial susceptibility, and the results, the final result maybe confound the clinician and start use antibiotic, and this is also the problem with antimicrobial resistance selection. This is, I think, very important. Through the role of the laboratory that receive, the staff responsible receive and process of the specimens, of course, and reporting the results back to the clinicians to guide the therapy or to interpret the results. But the main objective of the diagnostic stewardship is to deliver patients management guide by timely microbiological data to deliver safer care and more effective treatment and efficient patient care. This is very important. Accurate and representative antimicrobial resistant surveillance data. This is the second part, very important. It's not only to do safer care, to send safer care, send the results in a good way, but only have the data to create a very good quality surveillance, not only to inform to staff and also to treat the guidelines, but also to control infection control strategies. This is, I think, a crucial part. Clearly, this should be understood that this is, I say, an opportunity for a lab and infectious disease partnership. We need to strengthen our partnership. This is the very important part also. And diagnostic opportunities, not like responsibilities. I prefer use the term opportunities to the lab. And these opportunities include a systematic patient selection in a fast flow. It's not only to the lab technician receive 1, 2, 3, 100 cultures and start to processing, and sometimes they don't have time to read and to go to the clinical record. And maybe the patient number 1 is from outpatient service and the patient number 100 is from ICU. So we need to change our mind and start to create a systematic patient selection procedures and create a fast flow, to create a preferential information to send back to the clinician. Also, we need rapid tests. Of course, this is very important because the antimicrobial resistance in our setting in Colombia, maybe Dr. Carlos Alvarez last webinar told about our increased rates in carbapenem resistance in MRSA. So we need rapid tests for identification of microorganisms and also fast detection of resistance. This is very important. And also, I think the crucial part is, okay, you do the exam, you the test, create, but the information generation and communication to the staff. Sometimes the laboratory has problems in this part. Do everything very well, but the information stays at the lab. So we need to create some strategies to send fast the results. And of course, we have a very important part in education and counseling. Therefore, our laboratories now must acquire a series of skills in addition to perform the routine microbiology processes. Too many things to do. This is very important. In this process, the laboratory has, there are many implications in the diagnostic stewardship. In this new role of the laboratory, they have to work more and more challenging and include sometimes modify the process of order processings and reported of the request test. It's very important, this part, and make diagnosis with appropriate, current, and timely tests. Also, diagnosis must be appropriate for each patient. It's very important, and the kind of sample, the source of infection, the time that patient spent before at the hospital is very, very important. And the diagnostics test may have clinical relevance, of course, it's very important, and also as close to the patient bedside. I think this is the new paradigm. The laboratory has to move. It's not only in the laboratory do process, but they have to move also to the bedside, to the patient. And of course, we need to conserve the resources of the institution. This is the other part, because we want to have all the technologies, but of course, most of them are very expensive, and we need to be rational in the selection of the methodologies. Despite advance, there are still some gaps of technical limitation. We know there are some organisms that are very difficult to identify, and sometimes the techniques are not applicable to all of them. Also, for example, the techniques based on nucleic acid amplification has highly sensitive, we know, but we need antimicrobial susceptibility testing, and we need to receive the report, nothing to do. And sometimes there are limitations in attributing the resistant marker to a particular species. This is very important. Sometimes we receive like a multiplex PCR from orotracheal secretion, and we have BIM, but we have also Klebsiella pneumonia, we have also Pseudomonas aeruginosa, and we don't know exactly that BIM enzyme belongs to Klebsiella pneumonia. Maybe this is the pathogen that there are only colonization, or it belongs to Pseudomonas aeruginosa, and the clinician look the report and immediately start to put antibiotics. Is sometimes we are treating colonization more than infection because of these new techniques, if you don't use in a very rational way, with simultaneously routine culture to do for example, the antimicrobial susceptibility testing. Also, I think we need to view these technologies in other sense. We need to require integrate. I think integration is also the most important part. This is the challenge, to create a program, a workflow to integrate all the methodologies, all the techniques, all the equipments, all the systems, in order to have the optimal diagnosis for our specific patients. And one clear example for us in my hospital, in my country, maybe I think in most of countries in Latin America, is the challenge of detection antimicrobial resistance in carbapenem. There are different phenotypic, methods. Most of them are time consuming. The result maybe in 48 or more hours. Maybe the patient is too late for them. Now we have colorimetric methods. Carba and PS, very good, blue carba. Also, now we have in Colombia immunochromatographic methods that they detect the enzyme, specific enzyme for carbapenemase, and it's very good. And also we have in some hospital mass spectrometry, and this is very, very interesting. And now the panels, some commercial panels include this test in the commercial panel, and this is very good because each hospital has the opportunity to include all them, but in a workflow, in order to decrease the time to to have the results and to send to the clinician, not only for epidemiological purpose or to the infection control committee to do isolation, but only for the clinician, because the new antibiotics, maybe impact the outcomes, of course, and also we need to have more information about the kind of carbapenemase to orientate the therapeutic options. So, as Dr. Ponce de Leon said, the integration is the word in this session. And the integrative models I think is a very nice experience. The integrative model seems to be, I think, only one of the answers to the need to redirect the control bacteria resistance. The classical model here, as you know, divided diagnosis and the patient care and the laboratory, sometimes includes clinical expertise, versus the integrated model that it's very interesting because the implementation is a modern and rapid diagnosis. This is the first part. We need to have the most, I think, rapid tests with very sensitive in our hospital. Focus on individual patients is very important, and everything contribute to appropriate the use of antimicrobial, and also to do surveillance, infection prevention strategy. And this model allows all management teams work simultaneously, from the patient admissions to the successful of management of the infection problem. Now, this integrated is, of course, is impossible. This process cannot be managed by a single discipline. This is the other message. Is not only the lab, is not only the clinician, is not only the infectious disease consultant, is not only the infection prevention committee. Sometimes it's not only the hospital. We have remission in Colombia, in Bogota. Sometimes we receive patients from other hospitals with, I don't know, 3 days from carbapenem treatment with central light catheters, everything. And we need to talk together and say, okay, I received your patients, and your patient is colonized with the, I don't know, KPC, and we need to talk together. This is very important part. And management, in healthcare network maybe implies a interdisciplinary and integrated approach. So the classical model that we use now, we need to change to a model of integration. It's not easy. We need resources, we need training, but focus on the individual patient, and is for sure that it will be contribute more for the use and preserve our antibiotics. Now, let's focus a little bit in the responsibilities of the laboratory as part of the stewardship program. The first one, of course, is perhaps one of the main tasks that we are asked to do, is reporting susceptibility. All laboratory on the clinician go to know about susceptibility reporting. And this is essential to guide not only therapeutic options, to know the variation of the trends of susceptibility in the institution over the time, to support the empirical management decision in the hospital, to support also antimicrobial selection and database guidelines, because we need local information, and of course to consolidate information at the network and also at local and at national level. This is the challenge. Most of our countries, as Dr. said, start, I don't know how many years, to have surveillance at national level, but we need a very, very good quality at the laboratories level and the institution to create a very good information at national level. In that the last has the responsibility, of course, to generate the cumulative antimicrobial susceptibility data. We know about the cumulative antibiogram that we create according to international rules. We use CLSI standards, and also the lab has to talk with the infectious disease practitioners about the antibiotic use in our setting, in our hospital. Also, only report the representative microorganisms, more than 30. This is the rule, and talk and communicate these profiles to all the staff. And in this process, the lab has to educate not only the clinicians, but only, for example, the people who work in respiratory therapies and everything about the profiles. Our own profile is very important, but we need that all staff in the hospital know the profiles in susceptibility to guide the use of the antibiotics. Another responsibility of the lab is not about susceptibility only, but it's only about surveillance. Bacterial resistance surveillance is another responsibility to the laboratory. In general, our laboratories perform surveillance based on reports of prevalence of microorganisms. It's good, but sometimes it's only the number of microorganisms is a little bit tricky, but also the reports of prevalence of antimicrobial resistance. This is important. The prevalence is, of course, we need to use, but also is, if possible, some institution has the opportunity to do surveillance by in an active way, for example, search and screening people who go into the hospital or into the ICU and take samples and have to have the trends and do the more acute rates of resistant transmission dynamic. This is very good. The metric of antimicrobial resistance that lab had to do prevalence based of a clinical isolates is the number of isolates, of course, and the total cultures, but the number of resistant microorganisms is a tricky, I know, because the reports, the situation of resistance is a very good data to the general information, allow define empirical treatment schemes and help to design guidelines, but not provide information about transmission, no permit identify outbreaks and assess the impact of the infection control measure. This is a little bit difficult for all of our hospital. In many cases, the lab can also perform incidence-based surveillance. In this case, they report the number of isolates per 1,000 patient days, for example, or per device days. Needs not only to report the number of isolates, allows to approximate the trend of acquisition of nosocomial infection and evaluation of intervention, and also outbreak investigation. It's a very good quality, but no differential between infection and colonization or community-acquired or hospital-acquired microorganisms, and not allow to calculate the burden of disease, but it's very good. And the last, the laboratory can participate in the surveillance of incidence of infection. This is very interesting. Multi-drug resistant microorganism infections, not only the microorganisms, the infection caused by that kind of microorganisms or clinical syndromes, where the clinical context should be assessed in addition to the culture of the samples, allows to establish the burden of disease disease and evaluate the intervention. This is a very good quality. There are many, many examples. It's more robust than lab-based only. Data could support clinical decision, for example, about sepsis, meningitis, pneumonia, and sometimes we try to have the denominator and numerator about number of patients who had the infection and has susceptibility 1 or 2 more antibiotics per number of patients would have infection and antibiogram. This is very nice, but it's time consuming. It's not easy for the lab to go and find this kind of information. So it's clear that in our institution, until now, we have a very interesting experience, try to do our best to create, to have the technology, the equipment to try the do surveillance, but we need more. We need policies at the local and at the national level. I want to share some experience in my country, in Colombia. Until a few years ago, we don't have a national program or an action plan to combat antimicrobial resistance. Although we had been making efforts at institution and also network, I create a network named Grebo, maybe 14 years ago with Carlos Alvarez, and we start with our friends in Bogotá. And in the first time we were 15 hospitals, and then 20 hospitals, and then 30 hospitals, and we start to learn about HUNET, you know, the software from WHO, and we have the opportunity to create a very big database and share and try to understand what happened in Bogotá. And it was very nice experience, but it was our initiative. Now in Colombia, we have a national surveillance system with the same strategy, use HUNET software. And also we have now our program, our action plan from 2018, and the components of our plan includes, of course, education. I am a teacher in the university, and for us, education. And I think more than education is also training. Training is very important, and supervision of the process. And of course, communication. Sometimes hospitals and the laboratories, the laboratory has many things, but they don't have time to go and ask and share information and communicate. The other company is surveillance, and of course research is not easy because of the resources. Infection prevention is very important, and of course, and unfortunately, antimicrobial stewardship in our Colombian program is a component of the national plan. This is very nice. Also, we have responsibilities, and we have an action plan. The Ministry of Health, with the support of the Colombian Association of Infectious Diseases, create what do you say, technical guidelines, technical guidelines in antimicrobial stewardship that maybe now that will soon be a mandatory resolution. I think in this year, maybe in the next few months, this program, this antimicrobial stewardship program and guideline, it's really a technical guideline, will be resolution. And in these cases, they will be mandatory for all institutions. And all institutions must have to create the stewardship program at the institution, create all the process to implement it. Also, the hospital have to create guidelines or adopt guidelines, create algorithms and pathways. They have to know and to have informatics support and laboratory policies, and also the system maybe pre-authorization or audit to surveillance the consumption and the use of antibiotics, also education and evaluation. And in this scenario, the laboratory has a very important part, and includes the microbiology laboratory is part of the antimicrobial stewardship. Is a very important part. In Spanish, you say PROA. PROA means in Spanish Programa de Optimization Program for Antimicrobial Optimization, because we don't have exactly a translation of stewardship. But in these guidelines, the national guidelines include activities, responsibility for the laboratory, and is performed, of course, identification, antimicrobial susceptibility tests in timely way. The laboratory has to create or generate individual and global reports of the profile, not only for antimicrobial resistance, but also for healthcare infections and trends, and also generate warning system or alarm system when unusual profiles are detected, in order to improve the communication and feedback to the clinicians. And also the laboratory has to do, for example, antibiotics levels, aminoglycoside levels, have to do, for example, identification of carbapenem resistance. The laboratory has to do some tests to confirm, for example, MRSA, VRE, carbapenem resistance, and they have to create indicators and send to the local level at the Bogotá Secretary of Health, and also they send to the National Institute of Health. The indicators that we have to send are more related to prevalence data about a number of multi-drug resistant microorganisms, also number of percentage of healthcare associated infection, and also the incident rates of healthcare associated infection with, for example, bloodstream infection, or ventilator associated pneumonia, or ITU associated with catheter. But until now, we don't have the real integration. For example, we don't have indicator about how many bacteremias caused by MRSA we have, or we have to inform. No. Until now, we only have the prevalence indicator, but it's good for now. I think it's a very important effort for the institution, because we don't have all the same developed, for example, in technology and in training in lab technicians. So I think there are many things to do, but in conclusion, the paradigm shift in the use of the laboratory. We need to increase the support in the use of the laboratory. This is mandatory for us. We need to create the strategies to prioritize the detection of multi-drug resistant, encourage the use of the laboratory. We need to create alliance with clinicians, increase our mutual trust, optimize the diagnostic tools that we have, and we need to use in the best way, and also strengthen the quality control and the capacity of our laboratories. This is my point of view. Thank you very much for your kind attention. This is a very nice town in Colombia, near Bogotá. I have this house maybe 3 hours far from Bogotá, and this is greeting from Colombia for you, and thank you very much for this opportunity and for your kind attention. Thanks, many thanks.
Thank you, Dr. Leal, for bringing us the Colombian experience and some of the actions that you feel would like to see put in place to combat some of the antimicrobial resistance issues that you're facing on a daily basis, you and clinicians and laboratorians. We have a few minutes for the questions. One thing that struck me in when I was listening to both of your presentations is speaking about the importance. If you're going to try to reduce the burden of antimicrobial resistance, you have to have coordination between infection control, the diagnostic laboratory, and antimicrobial stewardship teams. And you're both emphasizing that heavily in your presentation. And And one thing that struck me, Dr. Ponce, and I'm gonna ask you this first. Of course, you identifying carbapenem resistance being associated with the use of the beta-lactam inhibitor, specifically piperacillin tazobactam. So I think it's interesting when you're tracking resistance and you're looking for root cause and things that could be affecting increased resistance in particular organisms. The other piece, though, is that you at the same time looked at these relationships of antimicrobial use and carbapenem use and resistance, but you also looked at hand washing and in that aspect. So it makes me wonder that when you're studying use of antibiotics and resistance and their correlation, you're missing a piece if you're not also studying infection control aspects, and perhaps just getting implementation of infection control can really help reduce some of your antimicrobial, as part of stewardship. But I think that's a piece that gets left out, and that really struck me. So how do you work with your infection control team? Do you share your surveillance daily? You talk about this daily basis of looking at each patient on antibiotics. It just seems like such an important aspect to me.
We work with them a lot, and we actually have cohorts of different types of patients with C. diff and with NDMs and all that stuff. It's just that what we found, we did this with all the patients, and what we found was that after doing the analysis is that it was related to poor hand washing, which is something completely different than the infection control program and not working. It's just simply that people don't do it. And if you look at the statistics in most our hospitals in Mexico, medical doctors are the ones that fail the most, and the ones that do it the best in terms of percentage of hand washing after looking at patients or whatever are nurses. So we do have a problem in the training, and medical doctors not are the ones that fail the most to comply with hand washing. So this is something that we found. It was not that we can. It was associated to it. Does not the only cause, but these were the only two factors that were associated: the use of piperacillin tazobactam and poor hand washing, with the detection of Oxat 232. So there must be lack of compliance, probably with COVID, where we had a lot of problems with infections all over the world. We saw that this is extremely important, hand washing and isolation procedures and all of that, because we had tremendous amounts of problems with bacterial resistance. And we also published that, and later on, and just sure, it was, we believe more than anything that because they were afraid, they were not complying with infection control measures. So obviously, that's what I keep everybody else say. I keep saying it. Doesn't matter if you have a beautiful antimicrobial stewardship program, if you don't have good enough infection control, is worthless. Also, if you have beautiful diagnostics, beautiful labs, if you don't have proper infection control and an antimicrobial stewardship, resistance is not going down. So you need to have everything in place and do the best you can. And also, these feedback and auditing are extremely important, because this is something that in Latin America is not well seen. It's not, I mean, and Dr. Leal, I think that did a wonderful job by just saying it. The auditing and the feedback in our countries is looked at as not something to influence your behavior, but as a direct attack to you. It's not the same as in the US or in Europe or everywhere. In Latin America, you feel that you're threatened if there comes a bad auditing or a poor review on, with the feedback. Something that we need to change definitely, but that's like changing the culture. It's not easy.
Absolutely. I just, oh, by the way, I was wanting to share the attendance code here. I just put it in the chat box. Here it is right there at the bottom for those collecting CE. Yeah, it's absolutely critical, but it's so striking in your study, the critical importance of that. And Dr. Leal, you also mentioned obviously the important connection of supporting your diagnostic laboratory so that they can focus in certain areas. They have time to collect data, report it in a surveillance fashion. The one thing I wanted to ask you is you mentioned also potentially even screening patients as they were coming into the hospital for multi-drug resistant infections upon arrival. Much like MRSA is, screened prior to surgery if you're a carrier, because you just the overall burden of these organisms in the environment. And so
Yes.
the hospital's then dealing with the situation that's coming externally from external. I'm wondering if that is something that you've put in place now or you're advocating for?
Yes. Yes, now in Colombia, we have a guideline about the patients who really benefit about active surveillance. And in Colombia, it's only focused with KPC producers because we have a huge problem in KPC. So we have more than 20 or 30%. So the hospitals have to do the first evaluation, risk assessment evaluation to the patient, and they create some inclusion criteria who patient really has the opportunity to do, for example, screening with the rectal swabs, for example. It's not for all, as you say, because how do you interpret the results? For example, MRSA, only, for example, for transplants patients and transplant is different, but not for all the hospital. In Colombia, only for KPC, but we risk assessment at the beginning when the patient come from, for example, other facility and has antibiotics for or some devices. The people have to have the inclusion criteria and do the surveillance. It's not only for everywhere and for everyone because it's expensive and how interpret the results.
But it seems like that's the appropriate focus. So, something as a takeaway for others to consider. We're actually out of time. I have many questions here. I think if any of the participants probably would like to reach out to you, they could. I think another takeaway with surveillance from Dr. Ponce de Leon's presentation was the importance of also screening the environment and wastewater so we can track. Could be an early indicator of multi-drug resistance within the environment, which will reach individuals that become patients and they become hospital problems. So I wanted to just, I know we have to go, but I wanted to highlight that information as well. And I'm sure more to come from you on that, Dr. Ponce de Leon, and probably also you, Dr. Leal, as you continue to lead surveillance efforts. So I appreciate your time. There's so much important information in this webinar, and I hope people will share it with their colleagues, maybe rewatch it, and support your efforts. Thank you so much. Yeah.
Thank you very much.
Thank you very much for your time, for your invitation. It was very nice experience to me. It was very nice. I really appreciate and enjoy.
Yeah, we appreciate all your efforts that, as you're impacting this in the global fight against AMR. So we look forward to watching your publications and more data to come, and hope to bring you back again another time.
Again, of course. Okay.